Assalamu alaikum everyone, and thanks for joining on the weekend. Today this lecture is more specifically for the based on the PALS and APLS guideline. Let me share my screen. You have the chat and Q&A button. Please continue asking me questions if you want to ask anything or if anything is not clear at all. So it's mostly for you all. So I have two screens in front of me. So I will keep an eye and will continue to respond to your question and answer in between. We will be doing a lot of kind of interactive question and answer, and I would like you all to put it in the chat so that I can know your mental frame and we can discuss. Thank you, Kabiru, for putting in your introduction and joining this session. I would say put it in the chat option rather than Q&A option so that everybody of you can know each other. So put your small introduction, what's your name, from where you are joining, and so that you can get to know each other. So as I said, today we are going to talk about, it's going to be 1.5 hour session, and it is the part one. We will continue this after on the part two, in 2 weeks time, and the dates will be informed to you. So we will do half today and then half on the coming date. As I said, today we are talking about assessment of critical pediatric patient based on APLS and PALS guideline. You all know APLS is a 2-day course and PALS is a full day course. So we are not able to do that, but I will be able to provide you the summary or the most important message, what it is out of it. About myself, I'm Jabeen Fayyaz. I'm pediatric emergency medicine staff physician at the Hospital for Sick Children, associate professor at the University of Toronto. My training background is pediatrician, and then I did my PEM fellowship at the same hospital, followed by I have a interest in education and specifically in simulation based education, and I'm the fellowship program co-director at the Hospital for Sick Children as well. And thank you everyone for putting your intros and from where you are joining, and I hope what we are going to learn is or talk about today is going to be meaningful, and you will learn some basic concepts and then you will apply it in your clinical setting. What on the pictures you can see is my this building. We have our sim center, which is, oh sorry, I'm apologize, I put the wrong cursor, and then you can see my amazing sim team here. So our learning objectives are very simple. We will discuss assessment of critically ill pediatric patient based on APLS, which is Advanced Pediatric Life Support, and PALS, which is Pediatric Advanced Life Support 2020 updates, and we are hoping to have new updates soon in October 2025. And as I said, my other hat is simulation, and even the PALS 2020 updates emphasize on simulation-based education and mastery learning. So I will talk a little bit about it. These are some of the societies and associations which I work, and I'm very happy that I am selected as a president-elect for the International Pediatric Simulation Society, and that is kind of my other passion in addition to the pediatric emergency medicine. With this, without any further delay, thank you so much everyone for putting your introductions, and thank you so much. I hope you are all going to connect, and if there's a WhatsApp link, can you please, I request our admin support to please put it in the chat so that they all can join the WhatsApp group as well, and they will stay connected. Coming back to the Pediatric Advanced Life Support 2020 guideline, the American Heart Association, you all know, update these guidelines every 5 years, which provide us with the essential protocol for the healthcare providers, and those include physician, nurses, tertiary care center, primary care center, anywhere who are taking care of critically ill pediatric patient. And these evidence-based recommendations help standardize emergency care for infant, children, and adolescent because these guidelines are up till age of 18 years. So release the latest one is in 2020. Every 5 year they announce. So we are hoping to have in October, November new guidelines like some changes. It will be totally not new, but yes, there will be some changes based on the research, based on the recommendation. The PALS covered from adolescent, from infant up till adolescent. These are not neonatal resuscitation. And afterward this, we will soon have a session more on management of respiratory issues, shock, as well as neonatal resuscitation. We will do that soon. This is our initiative covering the pediatric acute care management. And this all apply to in-hospital and out-of-hospital emergencies. If we look at the scope of the PALS guideline, the guidelines address the complete spectrum of pediatric emergency care. They provide protocol for management before, during, and after cardiac arrest. And it is designed, as I said, for all healthcare professionals. So like it's not that only tertiary care provider, only EMS, only doctors. It is for nurses, for paramedics, everyone who take care of pediatric patient. And as I said, it is for all age group, adolescent, children, and infant. The population which is not included are the neonatal resuscitation. It may not be as it is applicable with the congenital heart diseases and post-discharge neonate. So these are the three population which maybe all these guidelines may not be applicable. And the key principles of pediatric resuscitation, if you want to focus on or remember, are three. That is early recognition, provide high quality CPR, and a rapid response. Early recognition means identify respiratory and cardiac failure promptly and watch for subtle sign. Unlike adult, pediatric patients do not have overt signs. For example, in adult, you need low blood pressure, heart rate high, and many other signs and symptoms to diagnose or identify shock. While in pediatric patient, they can only present with fast heart rate, and it could be a first and only sign of shock in sick babies or sick children or adolescent child. So that is a major difference. So early recognition, prompt action, and providing a high quality CPR. And we are going to discuss like whole of our session is focused on early recognition, and then later half is quality CPR and rapid response. If we look at the epidemiology of cardiac arrest, almost 20,000 annual cases, even in US, and this does not include the cases which are happening outside US. So what is OCA? It is out of hospital cardiac arrest survival is 8%, and in hospital cardiac arrest survival is 30%. Despite of all the efforts, many years of implementation, you can imagine out of hospital cardiac arrest survival is only 8%, which is not great. In hospital is better, but then 30%, it means like 7 out of 10 children who present and who are in the hospital and have a cardiac arrest does not survive, which is not a very great number to be. Yeah, the PALS has updated, but they have not announced it yet. So we did not. I am one of the PALS instructor, and our institute teaches PALS. We do not receive them. Adults have already received ACLS, but we are still waiting. Thanks for that correction. I appreciate that. So the first thing that they have focused and they continue to focus, there is Muhammad Aman has raised the hand. I don't think so. I will be able to get someone to speak. Please put your comment either in Q&A or put it in the chat so that I can be able to read your response or your comment. So what the cardiac arrest they focus on is on the fact that to develop a system of care. As we discuss that having a system of care is very, very important. If we have to improve the survival and improve the outcome, then what is important is to develop a system of care that is that is only one thing. Just give me a second. If we improve in hospital management, that is not going to solely improve how these children will get or do after the arrest, or their survival will not be effective only if we improve our processes in the hospital. So the whole chain of survival that need to be improved is how they are being managed outside the hospital, on the scene, versus how their transfer is to the hospital, and then it comes to how their treatment is being offered in the hospital. So the whole system of care need to be improved or tackled upon if we want improved survival of the children with the cardiac arrest. So now focusing on this is from the APLS guidelines. That is why you are seeing their slides. The more important focus before even going into the updates, what they have make changes, we have to focus on recognition first, because if only we recognize, then we will be able to provide the best management to them. I still am seeing some hands up. Whoever is making the hand up, I would appreciate, please put your comment in the chat so that I will be able to read those comments and will able to answer your question. And thanks for putting a link to the WhatsApp chat. Please click that link and join the WhatsApp, and then we will continue even after this webinar to ask each other question. So now going to the recognition, the objective of this part of the session about recognition is to recognize or distinguish three components of PAT. And what is PAT? PAT is a pediatric assessment triangle. Which then after the PAT, we have to recognize or assess some pediatric specific features of initial assessment, followed by integrate these findings to form a general impression, and then to do a focused history and physical examination. I am also trained as a pediatrician, but when you are working in emergency department where time is money or time is life, you do not have time to ask a detailed history or do a detailed examination. So what the APLS guidelines are providing, they are providing you a rapid assessment that will decide how urgent a patient need your care, and then followed by a primary survey and secondary survey, which we are going to focus today in more details. I hope you have heard about Pediatric Assessment Triangle. Pediatric Assessment Triangle is journal impression done from the doorway or when you first see the patient. It involves using your eyes and ears and can be used to initially assess severity of the illness, how sick are they, and it determine urgency, decide initial emergency management, and prioritize care. So PAT is rapid and simple form of your immediate assessment. And it doesn't involve anything of your gadget, like no stethoscope, nothing. It is just listening and seeing without touching the child. And as you can see, three colors, which indicate three components, which is first is appearance, second is breathing, and third is circulation, which is like can be said in simple words as color. So appearance, breathing, and circulation, which is A, B, C, are the component of PET's triangle. And all of these three reflect child's ventilation and oxygenation state, perfusion, and neurological status. So let's deep dive into more detailed version. So I know some of you are joining who are working at a very higher level. So I would tell this is like very, very basic information and then followed by some updates. So probably it's a lot of repetition for those who are working at a senior level. Example is Huria. She's an assistant professor. She might know all these things already like maybe it's a repetition, but for me, I have done this lecture like more than 100 times, but still I learn and revise some of my concepts. So appearance is most important. It reflects adequacy of ventilation, oxygenation, brain perfusion, body hemostasis, and central nervous system function. So you cannot even imagine that just by seeing someone how much information you can find out. So the mnemonic which is used to assess the appearance or look for the appearance is tickles. It is TICLS tickles, which help to recall observation that give a journal impression or appearance. So assess from as soon as you see a child from the doorway, you will assess that child. And what are that meant is first is T, which is tone. Tone is normal motor movement as per the age. Is the child playful? Is the child interactive? Or appear limp or listless? So I is interactiveness. Interactiveness is the patient alert, irritable, lethargic. Does the patient respond appropriately to the environment or not? The C is consolability. Consolability is the patient easily comforted, consoled in more younger patient, infant, is he or she is agitated, calm, or very, very calm, not at all responding to anything. So that is C, which is consolability. Then coming to look and gaze, does the patient fix on a like what how the child interaction with the environment is, how the look is, how the gaze is the patient has glassy eyes, is the patient has like very, very like any sunken eyes or a very bright eyes. And the last one is speech or cry, which is the child is crying appropriately or talking appropriately, if the cry is weak, muffled, if the speech is hoarse. In infant with poor brain perfusion, we all know like if any CNS insult is happening, then you will not heard a strong cry. So abnormal appearance can be due to you are not diagnosing anything, you are just finding it out, is the child looks well or unwell, how quicker or how later I have to provide this child care, because I am talking from the lens of emergency department. And usually this PAT happens when either a triage nurse or a doctor see the patient first. We are so overcrowded in the emergency department or even in your ward setting or even in your clinic setting that we cannot sometimes provide first come care, first come first basis. So what we can do, we can use these simple techniques like it's that one is PAT, where we can decide who need our care urgently or who can wait. So this is first is appearance. Appearance can be abnormal due to many things like decreased oxygenation, infection, head injury, hypoglycemia, or any other thing, or respiratory compromise. You do not know. You just know that the tickles or appearance is abnormal. Because why? The tone is not normal, child or baby is not interacting properly, the child is not consolable, the look or gaze does not look good, or speech and cry. So this is what you will get from appearance. then you will go, for example, yeah, I just want to ask by telling you, some of you may argue, how can we find out a lot by just seeing someone? So this is a picture of the baby. So can all of you put in the chat, what do you see in the baby? Like how did this baby appear? Appear well, appear unwell, how the eyes are looking, how is the tone, like what information you are getting. And it could be any. Yes, very good. Salma is saying sunken eyes, lethargic, limp, unwell. You can see a cannula, so lying. So it means the child is sick. But imagine just looking at this. Do you want to make this baby wait? I believe none of you want to make this baby wait. So that is why, how much information. That's why I always say, spend your 1 minute at least just observing the baby. You will get so much of information. Sometimes I joke, like it's almost me working as an emergency physician from 2018. Oh, sorry, 2008. So it's almost like 15, 16 years of being an emerge physician. So sometimes I joke, like I just can enter the room and tell whether this child is getting admitted or can go home, because the pad provide you so much of information. So just move on to breathing. In breathing, you will is an indicator, definitely, because breathing you will have oxygenation and ventilation. The work of breathing is to provide you adequate oxygenation and to look for ventilation. So that is why if there is a work of breathing abnormal, then it will tell you that the oxygenation and ventilation is not adequate. So what you will do for the work of breathing, you will listen for any abnormal sounds of breathing, that either stridor, which grunting, wheezing, those are the sounds that sometimes can be heard when you listen. Then what you will look for abnormal positioning, for any, if the child is not like undressed, if the child is dressed, then sometimes you cannot be able to look at the retraction, but you can look at the tracheal tug, because trachea is most of the time visible. So abnormal positioning, abnormal retraction, nasal flaring, or head bobbing. So head bobbing is movement of the head with every breath, which will indicate the child is trying hard or breathing is fast, and is an indicative of respiratory distress. So let's look at this picture. What do you think this child looking? Does the, like, what is the position? What is the work of breathing? What are some of the things that you are noticing in this picture? Yes, Mohammed Ilyas, very good question. Adult patient have those critical signs few hours prior to arrest. Yes, definitely. These are the subtle signs. For example, a heart rate, tachycardia not getting better in pediatric patient is always a red flag. You should always prompt it, like perfusion poor, like you are giving, doing all the manage. We will talk about it. Let's hold off that thought and we will complete this, and then I will ask you whether it will provide you some of the guidance. Yes, thank you everyone for putting in respiratory rate. We do not, yes, by the PAT we can do respiratory rate. We are calculating the respiratory rate. So respiratory rate of this child is 70. Very good question. You can see retraction, you can see nasal flaring, you can see abnormal posture, mouth is open, the child look anxious. So see, from even just watching a picture, even the child is not in front of you, you can make so many things that, and you, do you want to wait this baby, or you want to provide immediate care? Is the child well or unwell? So are you able to make that decision? I will say yes. I'm making this. Just I could able to make this decision. Just seeing the baby, that this baby does not look like I can ignore what the child is looking. So now coming to an important sign, which is grunting. Grunting is a sign like somebody is in, like if somebody is in pain, karahana in Urdu, we call it karahana, or a sound like uh, something like that, this kind of noise. So that is called grunting. It is not similar to stridor. And later on, when I talk about the respiratory emergencies, I have the audios of wheezing, stridor, and grunting, and it will provide you more information. But just to understand, grunting is produced by exhalation against the partially closed glottis, and it's an attempt of the baby to generate the PEEP to prevent the airway collapse. So grunting indicates severe respiratory distress, or the child is going even into respiratory failure. So as I think Ilyas was asking, is it Ibrahim or Ilyas? Let me look. So I'm not. Yes, Ilyas was asking. So labored, like grunting is another sign that your child is in severe distress and the child may go into cardiorespiratory failure. Then the other thing is gasping. Gasping is again a sign of severe hypoxia. Like gasping is hypoventilation. They are doing some breathing efforts at an interval. And if there's somebody who is gasping, it means the child is almost at a pre-respiratory failure arrest situation. I would put a caution here when you are looking for the sign of distress. There are some children which may be very, very sick, but they do not have signs of respiratory distress. When it can happen, or what are the exceptions, is if the child is already fatigued and exhausted or going into respiratory failure. If there are CNS reasons, for example, raised ICP, decreased GCS, like decreased conscious level, poisoning, or any kind of encephalopathy, neuromuscular disease like spinal muscular atrophy. So these illnesses will not give you signs of respiratory distress, although it will give you hypoventilation kind of situation, that the child have a less breathing effort, and they still are very, very critical and dangerous. So therefore, respiratory distress is the most common presentation and most common sign. But these children, like especially if they are getting fatigued or exhausted, if they have a CNS problem, if they have poisoning or encephalopathy, may not present with the signs of respiratory distress. So this is an important thing or exception to be taken, kept into mind. Then we are going to see the skin is an organ that has easily been seen, or you can, it's mostly visible both early and late shock as well as the respiratory failure. So for example, pilar. Pilar is the first sign of poor perfusion in any patient, and poor perfusion can be because of shock, can be because of hypovolemia, fluid loss, blood loss, etc. Then the second is mottling. Mottling is a lacy kind of pattern, except for the newborn babies who may have this lacing pattern as a normal as a normal part of their skin. All the infants and like children or adolescent patients do not have these mottling as a baseline. This is because of the constriction of blood vessels, like decreased supply of blood to the skin because of the constriction of the capillaries and vessels. So it will indicate poor perfusion, and it's also a sign of shock. And in small infant, as I was telling, what I was saying, that in infant and neonate, it can be present as normal pattern, which is called cutis marmorata. So how you will make sure this is not the normal skin pattern, you will ask the parents, does this look more pronounced now, or that your baby has it on baseline? But usually after 1 year of age, you will not find cutis marmorata. It is more common in less than 6 months. But after 6 months, if this pattern is present, do take it seriously, and it could be a sign of shock or sign of precardiac arrest. Then cyanosis, which can be present, but it's a late sign, reflect poor tissue oxygenation, and can be seen in respiratory failure or cardiorespiratory compromise. I'm not talking about the cyanotic heart disease. Some cyanotic heart disease may have some element of cyanosis which is present at the baseline. So what we have talked about up till now in in almost in half an hour. See, only A, B, C, which is part of the PAT triangle, appearance, work of breathing, and circulation provide us so many information. So I would again emphasize, spend at least 1 minute or 30 seconds to 1 minute focusing on how the child appearing. Tickle is the mnemonic. How is the work of breathing of the child? And third, are the circulation, how is the skin look like, etc. One another that is e-certificate probably you will be provided, but that is the question I would ask, defer to the admin team of Apna Academy, and they will let us know, they will respond to that. So I would say another complicated situation before we will go on to discuss the case studies. Afterward, there are a couple of case studies and you have to participate in that. One caveat or one another complicating feature of pediatric patient is the vital signs are not the same, like for example at birth, at 1 month, at 3 years, at 7 years, at 12 years. So you have to keep in mind that the heart rate which is normal, for example in 3-month-old child, up till 160 heart rate could be considered as normal, will not be considered normal for a 14-year-old child. So you should have, this is the APLS chart and I really like the way. So you can get it laminated and keep it in your pocket, or even in your emergency department you can have it available in the form of a laminated sheet for your doctors, for your nurses, to refer to the heart rate levels so that they can make the decision whether the heart rate for this age range, respiratory rate, and blood pressure for this age range is normal or abnormal. So now move, yes, Salma is saying, yes, completely agree, Nusrat. It can be present in Down syndrome and some other illnesses. Very good point. So always correlate it. It doesn't mean that every children who has a mottling is in shock. So you have to put it all in context. Any child who is mottled will have some other abnormalities on the appearance, as well as on the vital signs. In children with mottling come and go, especially with fair skin. Yes, completely agree, Salma. So you have to make them warm. Cold temperature or difference in the temperature can also cause that mottling. Yes, Asma, the recording will be shared. I believe it will be shared with you all so you can watch it later. So first case study is, let's talk about a child who's presenting with cough, difficulty breathing. And here, what I'm saying, you are not focusing on the diagnosis, you are not focusing on what is the management, just focus on pediatric assessment triangle, because this is think of yourself just entering the room and then seeing the patient. So please hold off all your thoughts about the diagnosis, about the management. Yes, you can use by IMNCI as well, Amir. You can use any cutoff. I just presented one example. PALS has their own cutoff. Each hospital, our hospital, use a different cutoff. So use any cutoff, but make it a standard and do refer to that cutoff. Thanks for bringing that point. What I am showing are a couple of the examples. It does not mean this is the only way of doing things. There are many ways of doing the same thing in the best possible way. So please keep in mind as well. So first case study is a 16-month-old boy present with cough and difficulty breathing. The past history is unremarkable and he has congestion and low-grade fever for 2 days. Usually our triage is done by the nurses. Maybe it's possible that your triage is done by physicians and they can make that decision. Or you are the one who is seeing the patient, so you may not have this all information available. So you can only have an information that this is a 16-month-old boy who is presenting with cough and difficult breathing. So what you will do, you will do or see, look at the PAT. PAT is appearance. Appearance, child is alert, smiling, non-toxic. Breathing, you will hear an audible inspiratory stridor at rest. And circulation is the child appear pink or baby appear pink. So with this, I have two questions for you. What information does the pets tell you about that this child, what component of the child's presentation does it's presenting with respiratory issues, circulatory issue, is the child is in respiratory distress, is the child unwell or well with respiratory distress? These are the things you have to tell me. So I will go back again. The child is alert, smiling, non-toxic. You hear some audible stridor at rest with some tracheal tug, and the circulation is pink. Perfect. What I'm hearing, the child is in respiratory distress. We do not need to move this child immediately to the resus room. It seems like the child has some upper respiratory tract infection, some respiratory difficulty, but not respiratory distress. Completely agree. We are refraining for the diagnosis. We do not know what the child has. So I would not say acute laryngobronchitis. We do not know. Maybe it is possible when we take more history, the child has a foreign body and choking, and that's afterward having those symptoms. So do not jump on conclusion. This is the beauty of PAT. We are not jumping to the conclusion. We are keeping our differential very broad so that we will pay attention to all aspects. So it seems like a breathing problem. Child looks well, and we all agree that it is some upper airway issue because the child is having stridor. We do not know what is that issue. Perfect. Very good. So appearance is normal, breathing is abnormal, and circulation is normal because the child is alert, responding normally to his environment. His appearance is normal mentation, pink, but yes, he has some respiratory issues. So the child is in respiratory distress or have some respiratory issues. So after PAT, always remember we cannot make a diagnosis because we do not have enough information yet. What we can make is journal impression. And what our journal impression is stable. Stable, we have this habit of calling stable in our mind. Always remember, when you have to think something, you have to communicate that same thing so that the other person will understand. So based on the PAT, the child is called stable if all three arms of PAT are normal. If anything is abnormal, then you cannot call that patient stable. So usually they call it well looking or unwell looking, which is different from stable and unstable. But yes, we use these terminologies very interchangeably. Kuratulan, you have a hand up. I will not make this you speak. Please put your question or comment in the chat and I will be able to see that. Thank you for your patience. The second is respiratory distress. Third is respiratory failure. Then shock, CNS dysfunction, and cardiorespiratory or cardiopulmonary failure or arrest. And I'm just not saying that we have done the whole examination. Remember, we are talking about only PAT. We even haven't talked to the parent. We haven't talked to the child, haven't taken the history. We haven't examined. We haven't auscultated. So those impressions are my only journal impressions. So remember, like all of you can be like a little bit uncomfortable at this stage why all three arms need to be normal to call it a stable. So this is based on the APLS guideline. So they want to call stable if all three component of PAT are normal. And it is just so that when we are communicating to each other as healthcare provider, we know what does it mean. And if there is a distress sign or respiratory sign, then it is respiratory distress. versus shock versus CNS dysfunction and cardiopulmonary failure. Stable mean but not. Yes, I completely agree with you, Nusrat. That's why I given a caution already what we understand by stable. We want to, or we prefer some time to use this language because stable per se does not give much idea. Is well or unwell. So this is, it could be child could be stable, but as I said, in the APLS language, stable mean all three component of or arms of the pat are normal. And when you say stable, it means child does not need urgent care. So I will pose a question to you and you can tell me, how stable, ma'am? That I does not understand the question, Kurat. Can you please tell me more about it? What do you mean by how stable, ma'am? Can you please tell me more? What do you mean by that? Stable mean respiratory distress but not very sick as or in cardiopulmonary arrest. Completely agree. Then say respiratory distress, Nusrat. That's exactly the point. So if I would ask you a question, so you are saying if we say the child is stable and we do not have to do anything. Do you think that we do not have to do anything in a child who is having a stridor at rest? Tell me yes or no. Do you just walk out, walk away, and then say child is stable and child does not need anything? Or you want to start some management because the upper airway is compromised, like the child is having stridor at rest and you do not know why that stridor is. It could be foreign body. Right now child is stable, but maybe it could be epiglottitis. We haven't taken any history, we haven't checked any vital signs. So think from that mindset. Do not think that you have done all the assessment. At that time, I can understand why people are a little bit nervous that why it cannot be stable. So by stable, yes, I completely agree that stable stridor with crying or provoked, it's something different. But stridor at rest, need further something need to happen. It's not that you can walk away and you can say yes, this child can wait for 1 hour or 2 hour. So just to give you a case progression, and we will be talking about it in a little bit more later, because our aim right now is not how to manage, and we will have a whole session what is the management. So initial assessment showed respiratory distress with some sort of upper airway obstruction. So this information help us to establish our initial treatment priorities. So since this is a kind of upper airway obstruction and this child is having stridor, so management priorities is not to agitate more, obtain vital signs, and most importantly, oxygen saturation. Only if oxygen saturation is low, then you are going to provide oxygen, and then you will start some specific management. Yes, completely agree, Nusrat. I love the way you have put the explanation that how much response this child need. That's why PAT is important to avoid panic or calling more and senior, but to treat the respiratory distress. Very well said. And Strider is at rest. Early onset with no. Completely agree, Mihai. You nailed it, and all those comments are very valid. So the case, second case, is everybody is clear with the case one? This child has got abnormal breathing, have some upper airway obstruction sign. In the classification of journal impression, the terminologies we use are these. So you will use the same terminologies in our next cases. That is the child stable, and here we are saying all three arms of PATs are normal. Is the child is in distress, failure, shock, CNS dysfunction, or cardiorespiratory failure or arrest. And the child, in the beginning, you may not even assess all. You can have either the child is in shock or respiratory distress, or the child is in shock or maybe cardiopulmonary failure. So it could be two things as well. It doesn't mean that it could not be two things. So you can say stable with respiratory distress. So the two component are normal and the child is respiratory distress. But in our setting, we just call it respiratory distress. Whatever terminologies you will use or however you will classify, the important thing is you should all know or speak the same language. Now coming to the second case. Oh, Ilyas, blood gas. Blood gas is you will only do. I know some places have a trend. Any respiratory distress got a blood gas. We are like I sometimes get amazed that I can say I'm in North America and it is considered as a resource kind of very well resourced, but you will be amazed at how much less investigation I do since I'm here than I was back in Pakistan, where I was trained. I hardly remember any child who is in respiratory failure. Probably that is the one I will get the blood gas, because first blood gas is of no you can see clinically if the child is in respiratory distress or failure. Yes, in any children who you think will be intubated, you have to make the ventilatory decision by monitoring the blood gas. You will do the blood gas, but I hardly remember that we have done any blood gas on any respiratory distress who is coming in. I'm not talking about respiratory failure. I'm talking about the child who is coming with respiratory distress. You can see the child is in distress. I don't know what additional information the blood gas will provide you until unless you are thinking the child is becoming drowsy, the child is hypoventilating, and you want to see the CO2 retention. In that situation, yes, but that information you will get from the blood gas as well. Completely agree, Nusrat. Even then, it's not choosing wisely is a big initiative here. You need to know or justify if you are doing an investigation, what additional information that investigation will be providing. And we are a little bit derailing, but I think it is important to to address that, because we are not as resource generous as a lot of other settings are. And still, like, even if we have to order electrolytes, I have to order each electrolyte separately: sodium, potassium, creatinine, and I have to justify why I'm ordering. Here it is serum electrolytes, everything is done. Liver panel, everything is done. We have to order each and every liver enzyme separately. ALT, for this patient I just want to do as a screening, versus if I'm suspecting a liver failure versus hepatitis. So it's a big discussion that we can continue going on and on. We need to be very thoughtful when we are doing the investigation. Safina, the class will end at 10:30. The second case study is severe difficulty breathing. So there's a 3-month-old girl who is presenting with severe breathing difficulty. Okay, child was seen in the ED 2 days earlier and was sent home with a diagnosis of bronchiolitis. And but parent brought him here brought her here to the emergency department today again, because the difficulty breathing has increased. So what further information you would like to do or like to know is, first entering the room you need a PAT. What is PAT? Again, appearance. Appearance is lethargic, glassy stare, poor muscle tone. Breathing, marked sternal and intercostal retraction, rapid and shallow respiration, which is a sign of distress, and circulation is pale with circumoral cyanosis. Okay, so this is what the PAT you see. So what do you think? Appearance, what is abnormal here among ABC? Yes, Salma said emergency. Completely agree. I will call the call bell because I need more hands. This child is not looking well to me. This child is definitely in respiratory distress. Maybe in addition, shock or cardiopulmonary failure. I do not know, because the child appeared very lethargic, child appeared very pale. So the cardiac circulation component is also compromised here. Unwell, emergency, cardiopulmonary failure. Completely agree with all the thoughts. So appearance is abnormal, sorry. Breathing is abnormal and the circulation is abnormal. So What is your journal impression? How does this impression guide your management? So go to your impression. It is respiratory distress or failure with maybe cardiopulmonary failure, and management priorities is based on the vital sign. You will support oxygenation, ventilation. You may start preparing or thinking about intubation. You have to get an IV access, and you will do in this situation. If you want to do a blood gas, I will not argue, but then again, it's not a priority. The priority is airway management here. Okay, but yes, you can say that this child looks appear in respiratory failure, whether a decision of non-invasive ventilation versus invasive ventilation, you that either at least give you some baseline information, and then you can use it monitoring that after 1 hour after my management, what is the situation now. Thank you everyone who is participating. So the next case is about vomiting, a more common kind of presentation or not very acute. It's a triage complaint, vomiting. So what it is, 10-month-old child who is coming with 24-hour history of vomiting and diarrhea. Diarrhea is watery without any blood, and mom went to a health center who provide advice for oral hydration, and mom tried, and the child is not drinking at all. She called ambulance because the child appeared more tired and not feeding or not accepting anything to drink. So what we want to do, we want to do PAT, which is appearance, breathing, and circulation. So appearance, listless, respond poorly to environment. Breathing is effortless, tachypnea, no retraction, like there's no retraction, but the breathing is fast, I would say. And the circulation appear, face is pale with mottled extremities. Completely agree, Aisha. Shock. So appearance is abnormal. Breathing appears normal because the dehydration can cause fast breathing as well. There's no abnormal sounds. There's no retraction. There's no subcostal or intercostal retractions as well. And yes, completely agree. So here sorry, I skipped that. Appearance is abnormal, breathing is normal, circulation is abnormal. So initial impression, as all of you, most of you have nailed that it is shock, and management priorities is depending upon the vital signs. You may have to provide the oxygen, but the vascular access is the priority. You will start giving fluid and continue reassess. Very good. Yeah, Heba, completely agree. It's a shock. We do not know right now what kind of shock, but appear that because we haven't taken a history. That's why I said here we are reframing ourselves not to make a conclusion. Here we just know what is abnormal. We haven't taken any history. We do not know why this was happened or why this is happening. We haven't done a head to toe examination, but we know the child has diarrhea and child appear in shock. So my assumption based on my experience is that child is having hypovolemic shock because of fluid loss. But always remember, the rule of emergency medicine is not to jump on conclusion. Always go with a broad differential. Always keep on asking yourself why am I on the right track? So always question yourself. That is why here I am saying do not make assumption that this is because of this. Yes, most likely we always in emergency department or when you are providing emergency care, because I know a lot of pediatrician, lot of family physician, lot of adult internal medicine physician cover emergency departments. So we always say this is most likely explanation. We are not supposed to make any diagnosis. Yes, most of the time we are the one who are making diagnosis, but that is not the intention. When a very sick child come to you, you have to identify what is needed at the very critical moment. So with tachypnea, is breathing still normal? That's a very, very good question. So tachypnea, always remember, fast breathing does not mean that the breathing is abnormal. Breathing component is abnormal. Remember, we are not saying breathing is normal. We are just saying thanks for bringing it up. It may clarify other people confusion. Breathing normal mean breathing component of the PAT. The B of PAT is normal. So why we are saying, because the child fast breathing can be because of high fever, can be because of if the child is, you remember, in children breathing rate can be abnormal if the child is febrile. Breathing rate can be abnormal in metabolic acidosis, as somebody is saying, but in this context, if the someone is dehydrated, then the breathing may be fast, but it doesn't mean that the child is having respiratory problem. So breathing normal does not mean that the child, a tachypnic child, you cannot call breathing normal. It's the breathing component of the PAT is normal, it is said. Yes, completely agree, Nusrat. We have a child who come with respiratory distress, and the child is known to have asthma as well. So the child has some viral symptoms, and they were wheezing. We continue to manage the child with bronchodilators, and the child tachypnea. The child chest become very clear. Child continue to be tachypnic, and nobody is understanding why child is still tachypnic. X-ray was done, and still there was no pneumonia. So people decided, or the team decided, that we will get an IV access and start magnesium sulfate. And when we do IV access, we do send some electrolytes, because the child in our emergency department, we do not put IV on all asthma patient. Even moderate to severe one just get back to back Ventolin bronchodilators, and then we reassess them. So at that time, when they were doing some IV access, they decided to check the glucose, because the child was not drinking for 2 hours, and at home as well, and appear a little bit dry. And glucose, the sodium and potassium was sent, and the glucose was like high on the point of care glucose, and it was 37 something. We do it in millimoles, so the child was in DKA. So very well said, Nusrat. In fact, that is why I'm saying don't jump to conclusion. So in this patient, it was an upper respiratory tract infection, which trigger, all the time when children present with the first diagnosis of DKA, is an infection that has triggered their presentation to the emergency department. Same thing happened. This child is known to have asthma, use puffers all the time, have an upper URTI infection, and wheezing, and that may prompt them to be presented with high blood glucose. Yes, Patricia, completely agree. Check blood glucose, that is coming into soon, that where the blood glucose role is. So now coming to, everybody is good up till now. We are moving on to our case 4. All good? Thumbs up, fine in the chat while we are moving along. Perfect. Great. Thank you so much, everyone who's showing their presence. Now move on to the case study 4, lethargy. This is a 4-month-old girl who presented, or who brought into the ED by her mother after falling from bed onto the carpeted floor. Mother states that she took a very long nap, and still very sleepy, and it's almost 3 hours. At that time, there is no loss of conscious. Like, this is what information we know. I know people may have many other questions, but this is information we know, a very limited information from the triage. What we want to look at is PAT, which include appearance, breathing, and circulation. So let's look at our PAT. So appearance is child appear lethargic. Why? Because she's not responding very well to the environment. Breathing is normal and circulation is normal. So among the classification, is the child stable? Is in respiratory distress? Is in respiratory failure? Is in shock? In CNS dysfunction or cardiopulmonary arrest or failure? What do you think this patient is having? Unwell appearance, yes, because the child is appearance is abnormal. So among the classification, very good, very good. So now see, you tell me CNS dysfunction, and if you have taken or gone through this class, now everybody understand what does the CNS dysfunction mean. And it doesn't mean like everything, like you can have only one thing abnormal and you still can be unwell looking, because you are not going to leave this child who is appearing lethargic, who is not responding to their environment, and who has a history of fall from the bed. You are not, no way you are going to leave that room. You will be doing further things, and over the time we will discuss what does those other things will mean. So this patient have a CNS dysfunction. What is your priorities? You will look at the vital sign. Based on how is the vital sign, you may consider providing oxygen, close monitoring, IV access. You will check glucose, because remember I told you we do not know the reason. There is a fall from the bed, but it doesn't automatically mean that the child has a head injury. But yes, head injury is top of your list. It is the most likely explanation, but we do not know what else will come up when you take the history, when you do the primary assessment and secondary assessment. That is why I'm saying again and again, don't jump to conclusion after doing your PAT. PAT will only tell you, are you worried? You are okay to leave the space and child is stable and can wait, or you are not leaving the room without further intervention. That is the only thing the PAT is telling you. And then definitely you will decide to do some imaging. So, just to revise, PAT or journal impression is the PAT, which is the initial impression on overall physiological status. But then it will be supported or further enhanced by head-on assessment, which is your ABCDE, which are we are going to talk about in a minute. So what is ABCDE? It is similar to your adult assessment, but there are some differences, and it is used to identify life-threatening emergencies and in re-evaluating your care. That what is ABCDE? It is like help you in getting more information, and then when you are re-evaluating you will do your ABCDE as well. So what is A into ABCDE? A is look and listen. You will position the airway, you will do the suction. Yes, one thing here is, as now as you are doing a hands-on, you will identify, intervene, and treat as well. It's not that you will hear a lot of gurgling sounds and the child is lying with a flexed neck and not breathing and you will not do anything. You will continue to keep on doing some intervention. So you will position, you will suction, you will look for age specific obstructive airway support. This is like younger than 1 year and older than 1 year, back slap and chest thrust if it is a foreign body, like a basic airway maneuvers. And then manual airway opening maneuver, just as that is health tilt, jaw lift, and advanced airway technique. So you now notice that Pat, you are just watching. In your ABCDE, when you are hands on, you are doing assessment as well as managing the patient. Here also, you do not know what is the cause because you haven't reached to the history and you haven't reached to the secondary assessment. Then breathing is listening with the stethoscope over the mid-axillary line, and you will listen for stridor. Stridor is a hallmark of your upper airway obstruction. Wheezing, which is a hallmark of lower airway obstruction. Grunting, which is your hallmark of poor oxygenation. Pneumonia, drowning, pulmonary contusion are some of the causes. Crackles indicate fluid, mucus, blood in the airway, and it will indicate the lower airway, lung parenchymal disease, basically. And decrease or absent breath sound indicate the obstruction, and you should look for chest wall for abnormal movements, and definitely measure blood pressure. Fundoscopy come into secondary assessment, but definitely the blood pressure measurement is with the vital sign, which you will do in the primary assessment. But fundoscopy comes into, I would say, in secondary assessment. But yes, If that you are able to do quickly, you can definitely do it on your head to toe examination. I would say point of care transfontanelar ultrasound. It's a very good thought, and there is a lot of role of point of care ultrasound coming to the emergency department. And there are arguments that maybe at some point our stethoscope will be replaced by point of care ultrasound, some handheld device. But right now, I would say that will come also in your secondary assessment and in your secondary intervention, because you do not know the whole information. So you will do only the things which will make a significant difference at this time. Because you remember, like if for some reason we see a patient, we go to airway and breathing and we get to know everything, that is a blessing. But then in most of the cases, we do not get the whole information. And remember, from the quality and safety lens, the biggest mistake or medical error happen because of early closure. And why those, one of the reason of early closure is making conclusion or jumping to conclusion or going towards that route of investigation that may have a potential to dismiss the other causes. So I would say that the investigation and all other stuff, the point of care ultrasound, etc., keep it for your secondary assessment. No, Komal, it was not a temporary. I understand why you are saying, because the steroids sometimes give you high glucose, but in my whatever years, how many years of PEM experience, I haven't seen a hyperglycemia. Like I'm telling you in millimoles, you can time it with 18 and you will get in milligram per deciliter. Anybody's glucose to be more than 10 millimole, which is equal to your times 18, 180 milligram per deciliter or more, if it is because of just steroid or just a stress response. The child which I was talking about has a legit diabetic ketoacidosis, but it was missed because the presentation was respiratory distress. And I only bring that point, that how important is your reassessment is, and how important is to keep your differential always broad if the child is not responding in the way that you are expecting. But you bring up a very good point that high glucose can be because of the stress response and can be because of the steroid that you have given. But it will never be as high as 40 millimole or 37 millimole, which I don't know how to time it. I can time it with 18. Just give me a second. I'm finding the calculator. I know in Pakistan we used to use milligram per deciliter. So 37 times 18 will be like 666 milligram per deciliter. That can never happen with a stress response, or if it is happening, or maybe you have an experience that it has happened, just reconfirm it, because this is a very critical glucose level. Now coming to, we have look for airway, we have look for breathing, we are now into A, B, C, D, E. Okay, now C is pulse quality, central and peripheral pulses. You will again look for skin temperature and color. Capillary refill, you will check centrally and peripherally. And where is the capillary refill? You will check in small babies. Where is the spot you will check? Because their nails will be tiny, miny. So usually nails are not used. So where you will check the capillary refill time? Yes, completely agree, Nusrat. There wasn't stress plus prednisolone. Yeah, you did the right thing that you recheck it, but ours was like 37 something, and the glucometer was reading high. So that's why we decided, and then it was legit. We did the investigation and it perfect. Sternum, heel, sternum, very good. And in older children, you can check on the nail bed as well. That is completely fine. Blood pressure, there are some ranges which you can look from the chart, but this is a formula if you are good in remembering the formula. So this is a formula used for 1 year till 10 years. Less than 1 year, this formula is not applicable, and after 10 year is less than 90, basically is the 90 is the minimum blood pressure that after 10 years anyone should have. So this formula is applicable from 1 year to 10 year, that is 70 plus 2 times age in year, and that will be the formula. So I will tell you this child, for example, your child is 4 years old. So what would be the blood pressure, minimum blood pressure? Yes, Ada, thank you so much. In children with dark skin color, you will always check for on the heels. Perfect. So very good. Good job. So this is how you will calculate the heart rate by the formula 70 plus 2 times age in year. And this is the minimum level accepted. So I know if a sick child is coming to you, a systolic blood pressure is 78, you still will be worried because this is the lowest possible acceptable blood pressure. But yes, you do not have to rush to inotrope. You can give fluid or and then reassess. I have somebody's hands up. Probably they have a question, but please put it in the chat because I will not be able to unmute you. So please put it in the chat if you have a question. If you are raising your hand, Fatma. Fatma, can you put your comment or question in the chat box, please? And I'm just making my setting to all. Then disability. Disability is your quick neurological and mental status examination. APVU is a option, and we use in the research situation AVPU. And then later on in our secondary assessment, we use a GCS. What does AVPU stand for? Is alert, verbal, respond to verbal command. P is respond to painful stimuli, and U is unresponsive. Fatma, thanks for asking your question. Yes, both central and peripheral perfusion. Does it make difference? Let me tell you a scenario. A child is coming with drowning, for example, or exposure to cold. The peripheral perfusion is more than 3 seconds. And when you check this, drowning is not a good example, but probably a child who's coming with fever, tachycardia, the extremities are cold, and the perfusion is in older children. Perfusion is 4 seconds in your hands or heel. And when you look at the sternum, the perfusion is 2 seconds. So does it make difference in you? What you will do differently? Probably you will make the fever better, you will cover the child, and maybe in half an hour you will recheck. But yes, if the peripheral perfusion is 4 seconds and the central is also 3 seconds, then you are not going to wait. It will tell you how sooner your intervention is required. And peripheral, that's why pulses, even they said check peripheral and central pulses. It will just give you an idea that how much sick the child is, or are there any external factors which are impacting the circulation. So that is the only thing. But if you are just in a habit of checking the central perfusion, that is fair enough. But do not just rely on your peripheral perfusion. This is the message here. But yes, they are different. Where I was at the disability. In the disability, it is AVPU scale that we use in the ABCDE primary assessment. But yes, in the secondary assessment, we do the Glasgow Coma scale because it is very lengthy. But if you are good at it, you can still do the GCS score, look at the pupil, look at the posture. And here in disability, they call it DEFG. That is, do not ever forget your glucose. Most common cause of any child with a low mental status is hypoglycemia. which is very much missed. We do the point of care glucose at the bedside because sometimes the lab will take a long time. So this is in addition to having a point of care ultrasound and other gadget. This is a very simple test that can be done on the bedside, and it will give you a lot of information. So this is the posture. You can see, you can get some information, decorticate or decerebrate posture. It will tell you the child is having seizure. And the last component is exposure. Full exposure is necessary to evaluate physiological function and identify anatomical abnormalities, maintain warm ambient environment and minimize heat loss, and monitor temperature. Do not ever forget to fully expose the child. We have a patient who come with some sort of trauma. I don't exactly remember, and the child on the front exposure, the child was in shock. The fast was negative. There was no signs of any blood loss. But when we turned the patient, there was a big bruise on the back, and like there was a laceration as well. So on the scalp, which was not actively bleeding. So I was just telling that it is very, very important to do the full exposure. One case which I cannot forget, I saw in Pakistan at Aga Khan. So the child was coming with abdominal pain. So first day was discharged from triage because the child vital signs was normal, child was well hydrated, there was no red flag. Then a second time come in with severe abdominal pain and some pain, fever and some blood in stool. So then the child was taken into inside, and when I just make the mom was saying that he was having some pain in his foot as well. So I just exposed the leg, and they were all over rashes, and it was Hinox-Scholl and purpura. So sometimes these things get missed if you do not do proper exposure. So in exposure, you will always expose, like look for the all areas. You will keep the child warm, and you will monitor the temperature. So some pitfalls here to remember is in evaluating patient ABC, it is always important to treat all problems as you identify them. Any intervention performed should be followed by an immediate evaluation, re-evaluation of the patient to assess the effectiveness of the intervention. And at any stage, if you think your patient deteriorate, then immediately start your re-evaluation from ABC. You will not evaluate only that part. If the GCS become further worse or AVPU scale become worsen, then you will start from airway, breathing, circulation. You will not just look at the disability. So coming back, our fourth case, in the fourth case, when we did our ABCDE, they were gurgling upper airway sounds. Patient has irregular respiration. Infant look pale and then responding to a painful stimuli. Pupils were equal but react sluggish to light and show a big hematoma. So the case was managed as airway and breathing. This infant is suctioned and oxygen is given. A vascular access is obtained. Blood glucose was checked. A full neurological examination was done, and exposure fully exposure was done. And this patient or this physician who did the examination really liked the fundoscopy, as somebody already mentioned. They did the fundoscopy and they found a bilateral retinal hemorrhages. Exposure showed pattern of bruising and fingerprint suggesting shaking, forceful shaking. So what become your management priorities will be to intubate, secure the airway. This child is showing signs of raised ICP, then give the IV fluid and obtain a CT. The CT reveals a bilateral subdural bleeding, and skeletal survey showed multiple rib fractures. An infant is admitted, and father was the person who was responsible for the abuse. This is kind of yeah, NAI completely agree. Yes, Mihai, you bring up very good point, which we will be coming later, that we always have to check the right side pulses or the right side saturation, especially in younger babies, as Mihai has brought in, because in cardiac causes of low oxygenation, that is like if there's a lesion from right to left, like you will check forelimb, as you check forelimb blood pressure, there is a right to left side shunting, and you may have a normal saturation here but abnormal saturation on the left side of the body, that will indicate cardiac. We will talk about it, we have all that plan to avoid error in coarctation. But the good point here which Mihai has brought in, always try to check your saturation on the right side and pulses on the right side to check for any radial delay or radiofemoral delay. So focused history is the next step. Focused history in emergency situation, or as per the PALS or APLS recommendation, we are not going to follow the pattern that we used to follow while we were doing our pediatric training or working as a pediatrician, because their intention is to find out everything that need to be fixed. But in emergency department, we are more geared toward any abnormal or life-threatening situation or thing that need to be fixed. So we need that. So we use a sample mnemonic. And what does the sample mean? S is for sign and symptom, A for allergies, M for medication, past medical history or problem, last time food or liquid was taken, and then the event leading to this illness, or if it is a trauma, then injury. So the focused history mean a sample history, and then if you want to ask more, you are most welcome to ask. It doesn't say that you cannot take more history, but these are the bare minimum things that you should ask by a sample history, and then detailed physical examination to establish a clinical diagnosis, laboratory testing. So if I say bottom line is begin with PAD, followed by ABCDE, form a journal impression to guide management priorities, treat respiratory distress, failure, shock when recognized, take a focused history and detailed physical examination afterward, and perform ongoing assessment throughout your emergency department. So if I summarize or will tell you what you have to remember out of today's session is this slide. That is, after PAT, you have to perform your A, B, C, D, E, which is airway and breathing, where you have to look for effort of breathing, respiratory rate, any added sound, what is the auscultation, and color is in circulation, but you can look for color into airway as well. In circulation, you will look for heart rate, pulse volume, capillary refill time, skin temperature. I think skin temperature should come into exposure, but you can check into circulation. So I know these are a lot of components, but I will tell you that all of this can happen in less than 2 or 3 minutes time max, because you are not saying, I'm just looking for the airway and breathing. So if I'm touching a patient, I cannot assess the skin temperature, whether it is cool or hot. So you're actually doing all these things together. But yes, you have to remember in each component what you are doing. So in disability, it is mental status by AVPU, posture, pupils, and do not ever forget your glucose checking. And in exposure, fever, rash, bruising, any signs of trauma, any signs of blood loss. So this is what you are doing. Yeah, Mihai, we are adding an F to ABCDE. Tell me more. F for family. Yes, completely agree. That's a very good point, which we sometimes ignore, because when we are having a child, we are not only managing him, we are managing the family, the parents as well. And it's a very good thought. We are spoiled in a way that we have our child life colleagues and social worker who will take care of the parents. And once we have done the initial PAT, primary assessment, and the focused history, one of the junior is taking. So usually we talk to them, but I love the idea, and I will steal it from you, Mihai. I will tell in my next sessions that please do not forget to add F because it is for family. So I'm very, very grateful. With this, I think we have covered today's component of our session. And today's component, just to revise for everyone, is pediatric assessment triangle, which include airway, breathing, circulation, that is appearance, breathing, and color. Just even entering into the room and not doing any hands-on assessment. Then come your primary, and based on that, we will make our decision whether the patient is stable, which means all three component of PAT is normal. If the patient is in respiratory distress slash respiratory failure, is the patient is in shock, CNS dysfunction, or in cardiopulmonary failure or pre-cardiac arrest. And then we will go to primary assessment, which is our A, B, C, D, E, which is all our hands-on assessment. And I will add on F, stolen from Mihai, A, B, C, D, E, F. And then we will do focused history by using sample, which is sign and symptoms, allergies, medication, SAMP, past medical history, last meal, event leading to this illness or this injury. And then followed by your secondary assessment, which will include your investigation, more detailed exploration, etc. So this is what we discussed today. I know we took it 1.5 hours to talk about it, different aspects, and practice some of the cases, but I will tell you, PAT and primary assessment and sample history can happen in less than 5 minutes. And sometimes you are blessed that you have a junior learner with you and a nurse with you. So you will all do all these things together. Your learner is taking a sample history, your nurse is putting the monitor. So all these things are happening all together. So I would say 2 to 3 minutes time, you are done with your PAT, primary assessment, sample history, vital signs, and some focus leading to the secondary assessment. So with this, thank you so much for everybody's attendance, especially on a Sunday. I know on a weekend it's not always easy to spend time on these educational activities and leaving aside your families. It shows all of your commitment to learning and to contribute. And I'm very, very thankful to all of you who participated in the chat. And I learned a couple of good things as well. I appreciate everybody's attendance. If anybody has any question, I'm happy to take it now. And the next session, please remind my admin staff, support staff, when is our second part of this webinar, which we will be focusing on PALS updates. And I will try to look at probably the PDF version of 2025 are already available. So I will incorporate some of those as well. And I'm hoping that this webinar series will continue. And then my third intention is to talk about various kinds of shock, followed by respiratory management or respiratory illnesses. Perfect. Any questions? Let me check the Q&A section so I haven't missed. Thank you, every one of you. Like I always say, I'm the only one who are sharing some knowledge, but I'm learning from all of you. So ultimately, I'm the one who learned the most. Appreciate it. Yeah, and can you please share one more time the WhatsApp group link so that we will. Um, yes, we will try. You can listen, and then I will try to create some notes and share in the WhatsApp group if you are in there. Or maybe when we meet next time, I will share the notes as well in the PDF format. That's a good idea that everybody is providing. I would stay for 3 more minutes. If you are do not have question, please feel free to leave And I will thank you, Sadia, for mentioning. I'm very, very thankful to Apna for creating this kind of forum and providing us an opportunity to share our knowledge with whom a lot of people can be get benefited. And those who are like are at leadership roles, please feel free to share the this presentation link for next session with your trainees. I think it will be a good revision for them to come and attend, and it will be most beneficial for them as well. And then you can share the recording as well with them. I think Saima, they will like. I'm okay. Thanks for clarifying. There is no certificate for these sessions. 2 more minutes and then we will be leaving. Please feel free, who do not have any question, to just sign off and enjoy your day and time with your loved ones, with your families. Stay blessed and take care of yours in addition to your patients.